So in summary then, alternative payment models are payment methods of paying hospitals, healthcare providers, that deviate from fee-for-service payment. And there are many types of alternative payment models, as we just examined, and they all structure provider payment to better incentivize high quality and cost-efficient care. And just to make a few of these concepts a little bit clearer, so there are three key aspects. Each of these alternative payment model, everything other than FFS, is some form of value-based care. And this term VBC or value-based care is generally used to describe models of care that aim to improve quality and reduce costs, allowing LHS, large healthcare systems and providers, to succeed financially and clinically under these alternate payment models. And this improvement of care is both at an individual level and also for larger populations. And when we are talking about populations, as we saw, it refers to value-based care efforts to improve overall health outcome for a group of patients. So in the community, or the group of patients that are rostered and registered under your care. And such payment models often incentivize and focus healthcare providers to expend energy and invest effort on preventative care, helping improve the overall well-being of the community they are rooted in, and also ensure adequate focus on primary healthcare transformation. And finally, this is a payment model where the risk is moved. Today it is lopsided. Almost all of the risk in a fee-for-service model is borne by the provider and or the patient. All of the risk is borne either by the payer, the insurance company or the patient, and the provider, which is the hospital or the doctor, have very little risk. And here we make them financially accountable for patient outcomes and for the total cost of care when you deploy or implement an APM. Also, the degree of risk depends on how much money providers, which is hospitals, stand to lose or get penalized, or how much they can gain based on the outcomes, both financial, clinical, and patient-reported outcomes. And these are typically described in two ways. You have upside savings that are earned by keeping the population healthy, and the downside where there is a payment penalty. The question is, will this happen? What will be the rate at which healthcare providers will move away from fee-for-service payment, FFS, where it has really no risk and just keeps getting paid for doing more and more, to a model that is not still adequately tested, and to a model where it has to assume more risk and be more accountable for outcomes? There's no doubt that they will resist. Let us now look at how this adoption is trending and examine the forces that enable, encourage, and hinder these value-based care payment models, APMs, to flourish and become more widely adopted and deployed in our healthcare systems. Up next.